Intraductal papillary neoplasm of the bile duct. The role of single-operator cholangioscopy. A 71-year-old female was found to have abnormal liver function tests picked up on routine screening. She had never had jaundice or symptoms of biliary obstruction. Her past medical history included hypertension, gastroesophageal reflux disease, thyroid disease that required radioiodine treatment, total abdominal hysterectomy, and bladder lesions that required regular transurethral removal of bladder tumour. Physical examination revealed a lower midline laparotomy scar from previous hysterectomy, but was otherwise unremarkable. Abdominal ultrasound, computer tomography or CT of abdomen, and magnetic resonance cholangiopancreatography or MRCP all showed dilatation of the left intrahepatic biliary system with a lesion in the left hepatic duct impinging on the hilar confluence, suspicious of a small cholangiocarcinoma. Discussion at the multidisciplinary team meeting recommended an extended left hepatectomy to include the caudate lobe and radical bile duct excision until exact location and pathology was determined. Prior to surgery, a triple-phase CT of liver was performed, which showed stable appearance of the left hepatic duct lesion and no other hepatic abnormalities. In addition, an endoscopic retrograde cholangiopancreatography, or ERCP, and spyglass cholangioscopy was performed to determine the exact nature of the lesion. Cholangiography showed a normal right liver, but clear filling defect in the left hepatic duct. The spyglass cholangioscope was then introduced to further visualize this area. In this video footage, we approach the hilar confluence and obtain a clear view of the right hepatic duct and the left hepatic duct. It is unequivocal from this footage that the lesion seen on cross-sectional imaging is clear of the bifurcation. As we advance the cholangioscope into the left hepatic duct, we can see a villous tumour approximately 1 centimetre above the bifurcation. Manipulation of the cholangioscope into the bile ducts is usually straightforward, using manoeuvres similar to those required for placement of a long plastic stent. The cholangioscope can pass the tumour easily after 2 to 3 centimetres into normal-looking ducts in segments 2 to 4. Biopsies of the tumour are taken using spy-bite biopsy forceps to aid pathologic diagnosis. The spy-bite forceps may be difficult to pass due to the angulation of the cholangioscope within the duodenoscope. This may require the cholangioscope to be inserted or withdrawn for a short distance to enable the forceps to pass successfully. Once this is done, taking biopsies within the intrahepatic ducts presents no difficulties. Biopsies of the lesion showed papillary low-grade dysplasia with no evidence of malignancy. Given the potential for malignant transformation and the suspicion of cholangiocarcinoma, the decision was taken to proceed to a standard left hepatectomy and cholecystectomy. Pathology of the left hepatectomy showed IPNB, gastric type, that had been completely excised. There was low to intermediate grade dysplasia within the lesion, but no definite evidence of invasion. The patient made a good recovery and did not require any adjuvant therapy or further investigation. This case report illustrates the invaluable role of direct cholangioscopy in the workup of IPNB. Although cross-sectional imaging demonstrated intrahepatic biliary dilatation secondary to an intraductal lesion, the precise location and exact nature of the lesion was not definite. Spyglass cholangioscopy not only allowed direct visualization of the lesion to pinpoint its location, but also tissue sampling of the lesion to facilitate pathologic diagnosis. Exclusion of disease involvement at the hilar confluence during cholangioscopy helped inform surgical approach and the extent of resection required. In this case, a standard left hepatectomy was sufficient to achieve oncological clearance, avoiding a more extensive extended left hepatectomy, including caudate lobe resection and radical bile duct excision with Roux-en-Y reconstruction. IPNB remains a diagnostic challenge due to its rarity in the Western world and its propensity to masquerade as biliary stone disease. Successful management of IPNB, therefore, relies on a multimodal imaging approach, including the use of spyglass cholangioscopy and input from all members of the hepatobiliary multidisciplinary team.